Welcome, everyone, this evening. We just introduce Rachel, who is our guest speaker this evening. Rachel Madley is just a real gem, a real treasure in the single payer movement. Rachel has a doctorate. She's director of policy and advocacy at the Center for Health and Democracy. Works with our good friend Wendell Potter. And she previously worked as healthcare policy advisor to Congresswoman Pramila Jayapal, who of course carries the national Medicare for All bill. And before that, carried the state-based universal health care bill that we center a lot of our attention on, where she played a key role in shaping and reintroducing the House Medicare for All bill, did Rachel in 2023. Rachel earned her PhD in microbiology and immunology from Columbia University and has experience at the U.S. Food and Drug Administration. She's also active with PNHP and SNAP, Students for National Health Program, and has written for publications, including the New York Times. Very impressive. Love to hear your comments this evening, Rachel. Just walk us through a little bit, where we are and how you see us moving forward in the effort to get to universal health care. Thank you so much for being with us, Rachel.
Thank you so much for that wonderful introduction, Chuck, and to Mike for helping coordinate me speaking here. It's so incredibly exciting to be with all of you because I do think we are at a very uh, big moment in the move for single payer healthcare and guaranteed healthcare for everyone. And so I'm really excited to talk more about where we are in this moment, as Chuck mentioned, what we can do at the state and local level, and what the next few years might look like. So, as Chuck mentioned, I have been in the health policy space and the Medicare for All fight for a very long time. I actually got involved in this fight when I was diagnosed with type 1 diabetes, and I got a crash course in the cruelty of our health insurance system because I was uninsured and then underinsured. And like many of you on the call, had a lot of experiences where I struggled to get medical care, and I found myself thinking there must be a better way to do this. And so I've built my life around that and kind of within this movement. And I think since I have started in the movement, it feels like we are both in the biggest healthcare crisis in decades. So we are constantly fighting against the Medicaid cuts from the one big bill, the ACA subsidies that are about to expire on December 30th, 2025. But also, even though it feels like we're losing ground, we are also quietly making some of the biggest gains that we have in years. And so I want to talk a little bit about where those gains have been because I think we can learn from that. Then I want to talk about what the next few years might look like in terms of state and local action and also just the journey to Medicare for All. And then I would love to entertain questions, discussion at the end. So I wanted to highlight somewhere that we have made progress that was not in the news, on the front of the newspapers, things like that. But we recently scored a pretty substantial win in the fight against overpayments from the government to private Medicare Advantage plans. So these are plans that are administered by private health insurance companies like United Healthcare. There has been tons of research and data showing that these companies are overpaid by over $80 billion every year. So that's money going from the government, that's our taxpayer dollars, to these insurance companies. It's not a mistake, it's actually the insurers themselves gaming the system, figuring out how to get more taxpayer money than they are really owed. So, to make a long story short, in 2023, Congresswoman Jayapal led a letter urging the Centers for Medicare and Medicaid Services and President Biden to take action on this to stop these overpayments and reinvest that money into the Medicare program to expand Medicare. Now, it also had a lot of advocacy from folks who are on this call and a lot of allied organizations in the Medicare for All fight who are also focusing on this privatization of Medicare. Now, CMS did enact changes to limit those overpayments. It was not everything that we had asked for or wanted, but The biggest point here is that about a month ago, United Health Group told its Wall Street investors on a investors call that these changes, once they're fully enacted in 2026, are going to cost them $6 billion just in the year 2026. So that's $6 billion that they're not going to be able to use to lobby Congress. They're not going to be able to use as profits. And it's $6 billion of taxpayer money that's going to stay in the Medicare Trust Fund where it can really go to care for seniors and people with disabilities. Now, that may seem small and, kind of a wonky win, but this is really affecting the private insurance companies because they use the Medicare Advantage program as one of their biggest profit drivers. And so, just a quick example of obviously, it's not everything we want. It's not Medicare for all, it's not single payer, but it is progress that we have not seen for many years before that. And so, I think. What I really want to highlight is this shows that power can shift. So, even 2 years before this letter was led and these changes were made, there was another letter written by the health insurance companies that over 400 members of Congress signed on to. And that letter basically said the private companies running Medicare Advantage plans are great. Nothing needs to change. Give them more money. And members of Congress felt they could not speak out against the abuses in the Medicare Advantage program. So within 2 years, that has completely turned around. You have people on both sides of the aisle talking about the issues in Medicare Advantage plans and making changes that are really, really decreasing the profiteering. So, what I think we have also learned from that fight and also the fight for Medicare for All is that strategically, what we at the Center for Health and Democracy believe is that right now, big insurance companies are the biggest obstacle to improving our healthcare system. Obviously, there are issues with how hospitals are currently run and drug pricing and things like that. But if you look at the magnitude of the profiteering, big insurance companies are driving most of that. And so when we think about getting the policy change that we want, we feel we need to focus on one target, and that is currently the insurance companies that are using our healthcare as a way to make profit. And so, over the next few years, I think it is going to be important to focus on one target and one cohesive strategy throughout the Medicare for All and the health reform movement together because we are all fighting for similar things, but often we are fighting different opponents. So some movements are taking on the hospital systems, some are taking on big pharma, and some are taking on big insurance. We are stronger together, and the real root of a lot of these problems in our healthcare system is the big insurance corporations. And so if we can get policy changes that take their power away, then we can move on and address the problems in the hospital systems and the pharmaceutical companies. So, next, I want to talk a little bit about the reasons for hope other than the win that I mentioned before. We are, as you are probably aware, seeing a lot of hints that people are fed up with the current private health insurance system. Now, I know the people on this call have been fed up with the private health insurance system for a long, long time. I have been fed up with them for a long, long time as well. But the fact is, a lot of people for a while were just thinking, well, this is the way it is. I can't do anything about it. I'm just going to go on. With the expiration of the ACA subsidies, the increasing use of prior authorization, and the work that folks on this call are doing to talk about and storytell about how private insurance is affecting patients' lives and providers' lives, people are getting much more frustrated about the private health insurance system. And you don't just see that in individual comments. You can see it in lawmakers and members of Congress comments. So, for example, Representative Marjorie Taylor Greene has taken to social media to go against private health insurance company CEOs and things like that. Obviously, we don't agree on the solutions there, but that shows that members, even on the complete other side of the political spectrum of Medicare for All, are hearing from their constituents that they are frustrated and feeling like they have to speak out against private insurance. There was an article earlier today. Senator Mark Warner, who is a Democrat but has in the past said, I don't think single payer is the answer. Recently, he just came out and said, we have to go towards universal health care. There's no other option in this crisis. We also had a hearing in the Senate Health, Education, Labor, and Pensions Committee, also called the HELP Committee, the other day, and it was about healthcare solutions. Now, there was a lot of back and forth. Senator Sanders is the top Democrat on that committee, so he was talking about Medicare for All and why we need it in this moment, which was so exciting to see. Dr. Fagan from Physicians for a National Health Program was also on, she was a witness, again, talking about Medicare for All. The most interesting part to me and other folks are was that Republicans typically take the opportunity at these hearings, especially when people bring up Medicare for All, to cry socialism and talk about the wait times that they think would happen under Medicare for All and things like that. However, there was a notable absence of that rhetoric at the hearing. And rather than attacking Medicare for All, the Republicans chose to not engage in that conversation because they feel a changing sentiment towards private health insurance. And so, again, these are all small hints that we are moving in the right direction. And to the question, and my colleague Joey Rotino today wrote in our newsletter, Healthcare Uncovered, about Medicare for All, new polling showing that it's incredibly, incredibly popular, even when people are presented with arguments that used to turn them off from Medicare for All, saying, it'll get rid of private insurance, things like that. There is still very, very strong support for a Medicare for All system through with Democrats, independents, and Republicans. And so that is leading to this question of, is Medicare for All back on the table? And I think yes, 100% it is back on the table. It is back in conversation. What I do think we need to keep in mind as a movement, and I see the Medicare for All movement as all encompassing, right? So it encompasses the people working on just the federal bill, working on the state bills, working on both, because again, we're all working towards the same thing. I think the Medicare for All movement needs to start thinking about how the transition to Medicare for All is going to happen because it might look different than we envisioned. So, when I first started out in the movement, I envisioned, as Chuck was talking about, we would get a really solid economic analysis. We would present it to the lawmakers, and all the facts are on our side, and there's no reason why Medicare for All wouldn't be enacted. It would finally be passed and implemented in 1 to 2 years. Technically, all of that should be able to happen. However, in the current political landscape, it has not been able to happen for a very long time, as folks know who have been in this movement for a while. But thinking through how that transition might happen in different ways will help us be stronger as a movement. And I think that's one thing that One Payer States does really well because you are working on an implementation of Medicare for All state by state, so not at a federal level first. And I think that is a different roadmap than people originally envisioned. But as we all know, that's how it happened in Canada. There are a lot of really, really great bills in different states. When I was in graduate school, I worked a lot on the New York Health Act, and I know there are, bills across the country right now. So thinking through how do we as a Medicare for All movement, but also widening the tent, a movement of people who want guaranteed health care for everyone, how do we and allow that vision to coexist with other people's roadmaps of getting to Medicare for All where they thought it was just gonna happen overnight. There are other ways that it might happen, and I think we also need to think about those. There are a lot of bills, and someone just mentioned this in the HELP hearing as well, bills about opening up Medicare for people to buy into it. Now, originally, when this was being discussed during the ACA debate, a lot of people on the Medicare for All side bristled at this. And that was because a lot of those, public option type things retained a lot of the inefficiencies and weaknesses of private insurance, and also had a lot of risks, such as just attracting sicker, higher cost patients and things like that. But as a movement, is there a way to craft a Medicare buy-in program that creates the comprehensive benefits that we envision in Medicare for all? So not just the traditional Medicare right now that has a lot of weaknesses, like there is no out-of-pocket cap, there's no coverage for dental, for vision, for hearing. If we were to do a Medicare buy-in, and that's kind of how we can get there in this political moment, what can we do as Medicare for All advocates to get as close as possible to that Medicare for All system and put us on a glide path to get to that policy? In my opinion, I think that would be strengthening the benefits. So again, adding dental, vision, and hearing, adding that out-of-pocket cap, lowering cost sharing as much as possible, but also if it's going to be a Medicare buy-in, make it available to as many people as possible, because that, again, is getting us closer to our goal of Medicare for all. We want everybody in the Medicare program. And so there are also ways that it could happen that folks on this call may have not even thought of. I met a woman at the Healthcare Now and Medicare for All Florida Healthcare Resistance Conference, which was an amazing conference. I got to see Chuck there. But she was talking about how her county in Tampa, Florida, created they call it the Hillsborough County Healthcare Plan. And essentially, it is a plan for all people who cannot afford private insurance in that county. Now, they had a lot of restrictions on how they could create the plan. They can't necessarily do a Medicare for all on a county level, but they created a system where everyone in their county is now insured and people are not, you know, having to ration their medication and things like that. And so thinking through the different ways that we might get to Medicare for all and how we can all work together to make it a faster transition. I think that is going to be really, really important in the Medicare for all movement right now. And I want to acknowledge that it is really hard to think about it that way, right? Because healthcare is such a personal issue for so many people. For me, it is, right? Like I had to take out extra student loans to afford my insulin in college, and my parents worked multiple jobs just to make sure that I never had to go without my medication. And so the fact that we're going to have to take maybe different paths to get everybody to have health coverage that they can afford and use is incredibly frustrating. But I think right now we have an opportunity. And so we have to think, how do we make the most of this opportunity? How do we envision all of those different paths and make sure that we reach the ultimate goal of guaranteed healthcare for everyone, no matter which path we end up going down? And so I want to highlight a few specific things that you can do and be fighting for at the state and local level right now that intersect with those different paths. The first thing, which many of you are already doing, is fighting for single payer healthcare legislation in your states. I think it is incredibly promising to go down the state route, especially seeing what happened in Canada, but also looking at polling on Medicare for all. A lot of people who don't support Medicare for all say that they believe it's too good to be true. Because if you've been living in our private health insurance system, and someone tells you, hey, you can have healthcare more comprehensive than you've ever bought on the marketplace. It'll include your teeth, your eyes, your ears for the first time, no prior authorization, no out-of-pocket costs. It sounds like someone's trying to scam you. So there are a lot of people who sometimes believe it's too good to be true, and that decreases support. If we have a few states who make it happen, that is going to be so crucial for people to understand that it is a real possibility in the United States. Now, again, is it right that we are going to have a state as a model potentially for people to understand that this is possible? No. It's very frustrating, but it's a product of the health insurance industry for years putting out propaganda that a single payer system will not work. So I think the state by state pathway has a lot of benefits that maybe the federal pathway does not. That's not saying one is better than the other, but if we could get, a few states to do it and really lift them up as a model, I think it would make it much easier for us to do this on the federal level. Another thing that you can work on within your state legislatures is removing private insurance companies from your state Medicaid program. You may have seen it already. I'll put the link in the chat afterwards, but Physicians for a National Health Program actually did a report about how much money states could save if they removed private insurance companies from their Medicaid programs. Because some of you may not know, but companies like United Healthcare and Aetna have contracts with state Medicaid agencies, and they're actually the ones who are running the Medicaid programs. Now, of course, we know from the Medicare Advantage program as well as commercial insurance, private health insurance companies are incredibly inefficient and they're seeking profit. And so there is a lot of money that is being wasted in those Medicaid programs. And states have the power to remove those companies from their Medicaid programs. Activists in Connecticut did this and they had incredible results. I also see a lot of folks from Minnesota. Minnesota is working on this as well. And not only does it improve the Medicaid program and again get it closer to those benefits we're envisioning in Medicare for all, it also takes power away from the private insurance companies because the private insurance companies are making huge profits off of these Medicaid contracts. And so that's something that can be done at the state level. And there's a big opportunity there because state legislatures are looking for savings because of the cuts from the one big bill. And so this is something that really could move in this year in many, many states. Again, at the local level, I think the idea of county healthcare plans is very, very interesting. And it's a way to also talk to people in your area about the key principles of Medicare for all, of single payer in the state, but also of a county healthcare plan. And that really is everyone should have be able to get affordable healthcare. No one should be skipping the doctor, skipping their medication, going into medical debt because they need to get care. And so again, it doesn't look directly connected, but a county health plan could be a great way to talk to people, build support for single payer, but also make sure that people who are being harmed by the cuts we're seeing from the federal government are supported as we work to get to a better system. And so I think those are some really, really important things on the state and local level. On the national level, I would say the biggest thing that you can do, and I think that everyone in the Medicare for All movement can do, is always make sure you're at the table. Even if Medicare for All or single payer is not being discussed, if something within the healthcare realm is being discussed, people from our movement need to be at the table because we need to, one, continue to build support for single payer, but also prevent us from moving backwards. There are a lot of things that can be decided at some of those tables that, incremental policies can actually take us a step backwards. For example, when the Medicare Advantage program was being developed, the decision to let private insurers into the public Medicare program through Medicare Advantage was a step backwards from Medicare for All. And so, where are those places on the federal level where we can be at the table and continue to push for policies that are Medicare for all? And if Medicare for all is not on that table, how do we make sure that it's not moving backwards? So I know that was a lot of information, but I'll just end with saying I think the upcoming years, especially the 2026 midterms, are going to be very, very focused on healthcare. And then we get into the 2028 presidential election, which will be an open primary. And so that seems to be when those big transformational healthcare policies are really, really talked about. I know that seems far off, but we need to start working now to build our support and make sure that any candidates who are throwing their hat in their ring, no matter the party, no matter, what their beliefs, know that there is a huge, huge need for transformational healthcare reform that covers everybody, like a single payer on a federal level or a state level would do. So I think there's a lot coming up in the next few years. And with that, I will pause because I know there's a lot of questions coming in the chat. So would love to take any questions that folks might have, and I'll look through the chat as well to try and answer some of those.
That was really excellent. Thank you, Rachel. And I took notes as quickly as I could. And there are a lot of areas here that I am just so impressed that you have got such a great strategic mind and your ability to follow multiple tracks. This is a unique skill in our movement, and
Thank
it's a
you.
really valued and embraced one.
Mm,
Trust me, believe me. I've been at this work for a long time, and I can't tell you how much I value your thinking and your nimbleness. That's really, I think it's really, we have to be nimble, we have to be flexible, we have to see opportunity and not allow our
mm,
ideology, to get in the way of seeing it, right? We have this
Mhm.
blinder
mm,
oftentimes, some people call it, the purity test, but if it's moving us forward, we have to embrace it. And I know one person in the room who is very much of that same mind as Rose Roach. She's taught us a lot with labor for single payer in
mm,
Minnesota, healthcare for all. But let's start with Mary McDevitt, and I'll go through the chat. But we'll ask folks to come up, and if you do come up, please, please, please be very brief and get right to a question. Thank you so
mm.
much. Mary, and I know that we have Richard Godfrey, the longtime author of the New York Single Payer Group, in the room today. We want to hear from Dick Gottfried as well. Mary,
Can you hear me?
we got you. Thank
Yes.
you.
Okay. Somehow I'm not visible, but I'm a retired physician here in Sonoma and been working for years for single payer, and unsuccessfully and getting very discouraged. I read recently that private insurance companies have decided they're not going to issue Medicare Advantage programs anymore in certain locations in certain states. And I was just wondering, what is the possibility of a state like California saying that private insurance companies can no longer function in the state of California as of set date? What do you think about that idea?
That's a really interesting question, and I think it's a very interesting idea. My concern there, I think it would move us forward. My concern there is that health insurance companies are very smart, and so they could find a loophole and, dissolve and then recreate themselves as a different type of company that is not prohibited in the bill. I will say, so I think it's a very interesting idea. I would also worry about the lack of a program to take the people who are coming out of the private insurance because, and I think one of the reasons that we're in this situation is because if you don't qualify for Medicare or Medicaid, the only choice you have is private insurance, whether it's through your employer or through the ACA marketplace or things like that. And so we do need a program to allow those folks to go into. It could be, that they can buy into Medicare or something like that. So I think it's really interesting. I'll also say Representative Pocan, who represents Washington in Congress, recently introduced a bill that would prohibit any insurance company that had defrauded the government from participating in the Medicare Advantage plan. It's a very interesting method because pretty much all of them have defrauded the government. So a lot of them would not be able to act within the system anymore. So it's a
Yeah.
very interesting question.
Yeah, here, let me just add to it quickly. Here in California, what I would suggest is that the state of California contract with Kaiser to provide health care for everybody in the interim when the private insurance companies are no longer allowed to function.
hmm that would make a lot of sense. And also if you think about, again, the different paths that we can use to get to single payer, traditional Medicare actually uses what are called Medicare administrative contractors. They're third-party administrative companies,
Mm.
but you have probably never heard their name before because they are not like out for profit. They're not doing prior authorization, things like that. They're simply authorizing the claims. And so if you were to design something like that, that could even be where people buy into a Medicare program that's administered the same way.
Thank you.
Okay, thanks, Mary. Let me go over. I see Hank, your hand is up, but let me go over to the chat and try to work through that back
You
and
bet.
forth if we could. So there's a question about half an hour ago that came in from Ralph Eckles, I guess, from Oregon. Cost of current Medicare, difficulties, physicians, formularies. Could a state have one formulary and PA status for all current insurance plans? Is that
So that's a great question. And It would be difficult for a state to have one formulary without also having, I mean, they could definitely require that. There's an interesting example of Ohio recently, and again, this is a Republican trifecta, so Republican governor and state legislature. They recently removed the private pharmacy benefit manager from their Medicaid program because they were so frustrated by things like the formulary and the waste of money. They've saved a ton of money and also been able to increase the dispensing fees to pharmacies by over 100%. So they're saving small pharmacies, things like that. So those types of legislation focused on PBMs and the formularies definitely have a lot of promise. And I would urge you to look into what Ohio did because, again, it was passed under a Republican administration, and they're touting all of the successes of it. And so there's a lot that we can do there. In terms of prior authorization, a state could technically do that for some insurance plans. They could not do it for employer-sponsored insurance plans because those are regulated by ERISA, the Employee Retirement Income Security Act, which prohibits state laws from regulating employer-sponsored plans. It's kind of complicated and it's definitely tough to get at those plans. So if a state wanted to do that, it would only apply to some of the insurance plans in the state.
Okay. All right. Thank you so much. Let's see, Hank, and then I'll jump back over to the chat. Hank, quick
All right,
question.
thanks. So the question of fast versus slow, what if you've modeled or thought about that? Slow being, let's say if the age goes down every 5 years for 5 years, Medicare versus you go from 0 to 18 or 26 and get the kids covered because they're
Mhm.
easier, cheaper, and the pediatricians get a pay raise, the various. But the question is slow roll in versus what happens to a private equity or a stock fund who realizes that the rent seeking the take from their health insurance model then goes away? How quickly will insurance companies collapse, fold, get out of the market? On a state level, if we do a model state plan, Cigna Anthem would lose, in Maine would lose 0.5% of its business or something like that, not a threat. But in a
Mhm.
national level or a major state. So I don't know if you folks have modeled a fast versus slow. What's your thoughts on that regard?
That's a great question.
Or collapse in 2027, shall we say, under the big beautiful bill?
Mhm. Such a great question. We have not modeled it to that amount of detail. I will say that I think if we were to do a slower transition, my preference, and I think the safest way, would not to do an age band because then the people who aren't able to get into that Medicare for All program yet may be hurt by the collapse. I think an option to buy into the Medicare program until we got to our ultimate goal of single payer would probably be safer because different markets are going to react in different ways, right? So, as you mentioned, one state, it's not as big of a deal. Another state, the private insurance market may collapse. Now, I will say we are seeing that happen right now because of the ACA subsidy expirations. So we have in Michigan, I believe, in many places, there's only one carrier offering plans on the ACA marketplace. We're also seeing a lot of Medicare Advantage insurers pull out of different markets throughout the country. I think somebody mentioned that earlier on the call. And so we're starting to see that collapse. It's not going to be overnight because these insurers have made so much money in the system that they are going to fight tooth and nail to keep that money. It's going to make our jobs harder, but also they're not going to back out overnight. But I do think having a something that's open to everyone, even before everyone's automatically enrolled in a Medicare for All system, is a better way to go to prevent any downsides from that collapse. And I also think it's interesting to think about, again, those different pathways to Medicare for All. If we create a Medicare open enrollment buy-in type thing that is so above and beyond better than private insurance, you're not having to deal with prior authorization, things like that. Can we make health insurance companies a bad investment, right? Because as we are able to make them a bad investment and Wall Street investors are like, yeah, we're not seeing returns on that anymore. No one wants their plans. They're crappy, things like that. It makes them a weaker opponent. They're going to have less money for lobbying. They're going to have less money for campaign donations. And so thinking about the path to Medicare for all in that sort of way has really helped us at the Center for Health and Democracy because we also need to weaken our current opponent. And there are ways to do that while we're improving access to care.
Terrific. Thanks, Hank, and thanks for your deep, thoughtful reply there, Rachel. Also from Maine, Julie Pease asks, how can states leverage power to go after the insurance industry?
That's a great question. And I want to go back to what I talked about with states who have private health insurance companies administering their Medicaid programs. Those companies make billions of dollars, sometimes depending on the size of your state, managing those Medicaid contracts. And so that is a way that you can directly ask your state legislature and your governor to stop contracting with those folks. In Connecticut, that transition away from private Medicaid managed care was very, very quick. And so I think that is the biggest way that you can leverage your power within a state to kind of reform private insurance practices by getting them out of that Medicaid program. Also, the example that I brought up in Ohio, even if you can't get private insurance fully out of your Medicaid program, can you get the pharmacy benefit manager to not be a private insurer anymore, but to be your state government? So fully public, no middleman, no spread pricing where they're scraping money off the top to pay for people's prescriptions. I think those are two key things. And oh, Julie, you see, great. So Medicaid program is already publicly run. In that case, I would say some states have actually taken action on prior authorization. As I mentioned before, they can only regulate certain insurance plans by the state. Other insurance plans, like employer-sponsored plans, have to be regulated federally. However, the state can set certain guidelines for what you're allowed to require prior authorization for, what you're allowed to require step therapy for. And not only does that increase access for patients and decrease costs, again, it also weakens the insurers because they're being forced to pay money for care that they wanted to keep as profit.
Excellent. Yeah. I mean, in this environment where we are right now, the call for states to take action is really so paramount, so important. Thank you for that detailed response. Tom Sinsick of Portland, Oregon asks, how do we prevent insurance companies from diversifying into owning delivery systems?
Such a great question, and something that we at the Center for Health and Democracy have been thinking about for a long time. Over the summer, we released a report called the Sunlight Report on United Health Group, and I can share the link in a bit, where we mapped United Health Group, and we found that not only is it an insurer as we know it, but it also has 2,694 subsidiaries, many that are within the care delivery system. So provider clinics, pharmacies, home care organizations, things like that. There have been bills that have been introduced, and this is another area where I think we're starting to see a real tipping point because one of the bills that has been introduced is led by Senator Elizabeth Warren and Senator Josh Hawley. So, two very different ends of the political spectrum. It's called the Patients Before Monopolies Act, and it would prevent insurers or pharmacy benefit managers from owning pharmacies. So, again, it would cut that tie that often leads to self-dealing. There's a similar bill that was introduced by Senator Merkley, and that bill would prevent health insurance issuers from owning a medical provider. Now, Kaiser is carved out, and places like that are carved out where it was a hospital system that then started an insurance plan, but it would prohibit a United Healthcare being owned by United Health Group, which also owns Optum physician practices. So those bills I think are another thing that we can really be working on in the near term because, like I said, they have bipartisan support. There's a lot of support for kind of anti-corporate greed measures, even on the Republican side. And so I'm so glad that you asked that question because that is one of the things that we can do in the near term. So that's the Patients Before Monopolies Act and the Patients Over Profits Act.
Terrific. Yeah. Thanks, Tom, for the question, and Rachel. Um, I know Charlie Swanson has a few comments in the chat. I don't know if you have any questions there, Charlie, if you want to come up and ask if you do have a question or you're just commenting just as we're tracking here. We have somebody, P Tag. I'm not sure who that is, but in your view, what's the most fruitful way to use the Connecticut experience and example?
Yeah, so I think looking at the Connecticut experience and the direct results. And so there was a great study that's referenced in the PNHP report that compared Connecticut after they got rid of the private insurer in their Medicaid program to New Jersey. I actually live in New Jersey, so I thought this was super interesting. New Jersey kept the private insurer managing their Medicaid program, and they found really staggering things, not just in savings, which I think is going to be really, really helpful when you're talking to legislators who are looking to fill these gaps in their budget that are left by the Medicaid cuts. But if you look at the health outcomes, they saw a significant decrease in ER utilization, which again gets at savings, but also greater long-term health. They also saw a rise in early cancer detections. And again, that is savings that were not even counted in that, 1 year that they were calculated, because that's someone who would have, their cancer probably would have been caught 2, 3 years down the line and led to very expensive treatment rather than being caught early on. But also, you're improving these health measures while saving money. So I think combining those results are going to be really, really important when you're talking to state legislators.
Mhm. And we might add that to make these accomplishments in the insurance capital of the country, Connecticut,
Hmm.
is also, it should also be encouraging, right, for us, the work that we're doing.
Definitely.
Yeah, yeah. Charlie, your hand is up. Charlie Swanson from Eugene. Hey, Charlie.
Yeah, yeah. So I've got a question that I did put in the chat, but I did have some comments as well. So my question is, are you familiar with Hayden Rooklay's notion of um, mitigating some of the cuts to Medicaid by essentially increasing payments by states to Medicaid providers? And so basically the price parity notion, and therefore drawing down more higher federal match and getting us closer to the equity that we want. So it does a couple things there. So I'm wondering if you're familiar with that and if you have any thoughts about that.
Definitely, and thank you for that question. Yes, very familiar with Hayden's work, and I am very supportive of that. And I think it gets back to my point about different pathways that we're going to get places. Because in that instance, you could also think about, well, what if we expanded it to commercial plans as well? And so like standardizing prices so that we people knew how much things cost. From an insurance perspective, that's going to take away their most of their game, right? Because they're, negotiating for contracts and profiteering off the top and then paying the providers that they own more so that they can keep more in profits. And so, yes, very excited by that idea. And again, I think it gets back to there's a lot of different ways that we can get to, like you said, the equity that we're looking for.
Terrific. Thanks, Charlie. Thanks, Rachel. Let's see. Betty, your hand is up. Where are you from, Betty? You went on mute.
Portland, Oregon.
Okay. We got
I
the
was,
Oregon crowd tonight. Yeah, go ahead.
yes, I was working for NIH Clinical Research Center back in under the LBJ administration, and it seemed to me, and the department heads in our hospital thought that original Medicare went through amazingly fast. And it seems like now we're making it sound very complicated. Well, I'm sure it is, but is it my imagination or are we taking longer?
Not your imagination. We are 100% taking longer to get there. I think the reason, a big part of the reason is because the health insurance industry is much stronger than they were and also
Mhm.
has a lot more to lose under a single payer system than they
Yeah,
did under the original Medicare system.
right.
Um, but in terms of implementation, that's one thing that I think is really exciting because, as you're probably familiar with, Medicare was implemented very quickly and pretty smoothly.
Right.
But an even more recent example is during the Affordable Care Act, Senator Max Baucus from Montana got a
Yeah,
provision in there exactly where essentially we have a single
exactly.
payer in Libby, Montana. There was a great
Yeah,
video by More Perfect Union on the implementation, and again, it was very smooth and very simple, and the people there love their Medicare.
right.
So that's a point of hope. Our obstacle and opponent to getting the legislation passed is much stronger than when Medicare was passed. But the implementation, I think, is going to be smooth because, again, when they were implementing Medicare, they were doing it on index cards, right? We have so
Right.
much more technology like that. So the fight to get there is going to be harder and longer, but the implementation, especially because of the work of folks on this call, to go through the policy and make sure that it's ready, the implementation is going to be, I think, smooth.
Right. Thank you.
Thank you. Thank you, Betty, very
Uh,
much. Yeah, Julie P's also had a question about models, county models that you discussed or mentioned earlier. Yeah, and in the case of Maine, she mentions that is there something like a rural healthcare model as well, like rural counties? Um,
That's a good question. I am not familiar with a rural model like that, but there very well could be. And I think it's interesting to think about, but I apologize, Julie, I am not familiar.
okay, okay,
And Chuck, I'm sorry, I do want to answer one quick question in the chat
sure,
from
sure. Go ahead.
Dave Garibaldi from Minnesota,
Sure.
about, you know, is there thinking about a public option Medigap supplement, which would keep the premiums paid by enrollees in the traditional Medicare trust fund rather than lining the pockets of insurance companies? There's definitely been talk about that, but what the Center for Health and Democracy has been focusing on, along with some folks on this call, like Rose Roach, is instituting a low out-of-pocket cap for traditional Medicare so that Medigap plans are not necessary to enroll in traditional Medicare. And that we think would be a more direct way to get at what you're talking about, to again allow people to choose to go into traditional Medicare if they're in Medicare Advantage without needing a Medigap plan, because there's this thing that, people are starting to call the gap trap, which is essentially folks who are low and moderate income cannot afford to pay the traditional Medicare premiums plus a Medigap premium. And they feel that their only choice, and really their only choice right now, is Medicare Advantage plans that have lower premiums and have an out-of-pocket cap. So if we can put a low out-of-pocket cap in traditional Medicare, we can achieve that goal and also really, really strengthen the program.
Terrific. Yeah, I'm certainly in that category. Thank you for that, Rachel. We'll turn to hands again. Let's see, Mike Huntington, another Oregonian. You guys have just raided the call here. Mike?
Yes, thanks, Rachel, for speaking tonight. When you were working with Representative Jayapal, the State-Based Universal Healthcare Act did not contain a line that it now has. And it is that states must fund certain services. In spite of this not being a prescriptive bill, it does prescribe that states must fund abortion and transgender care. What is your advice on trying to get that out of there? Or do you agree that it should come out?
That's a good question. And so I will use an example from when we were reintroducing the Medicare for All Act when I was working for the Congresswoman. Um, we actually made an addition because it had covered reproductive health care, but it didn't have specifically the word abortion in the bill. However, we were now reintroducing it after Roe v. Wade was overturned, but also after the first Trump administration, having seen what they were able to do, whether it was legal or not, when there is a rogue secretary of a department. And so we did choose to make the bill more ironclad to prevent that from happening. Because let's say we finally had a Medicare for all system, and then 20 years down the road, we have another president like our current president and the secretary of HHS,
Mm,
says that only acupuncture is covered under Medicare for All now or something like that if it's left
mm,
up to their discretion. So we felt that it was really, really needed to make the bill airtight. I think in this case, it is difficult because, as you say, it's not meant to be a prescriptive bill. But I do think
mm,
that right now, with the bill, um, and mainly, Democratic states being the ones that are going to try to enact single payer legislation. And I know, there are states that have figured out how to do it even without waivers. So if that bill were to not pass, obviously it'd be much easier if the bill were to pass. I do think that
mm,
it probably makes more sense to focus on kind of the larger fight right now, but flag that concern for the person who's leading the bill when it's reintroduced. But I do see the reasoning for it, and I think it's because especially,
mm,
members of Congress are seeing up close just how dangerous it can be when a law is left open to interpretation, and so they're trying to put close all the loopholes as possible in their bills. Um, so it's a tough question, but I would say I think it's something to focus on down the line when, there is the possibility of a Republican state wanting to enact single payer, but that's a provision that's stopping them. Because right now, I think we really want to unify the Democratic Party behind this idea, because it is currently being supported by people in that party. Even though we welcome Republicans to come support it as well.
Yeah.
Thank you.
This is a much longer conversation. We could spend days on this one. I know, having done this.
Yeah,
We've
and I'd be
been put
happy
some,
to talk about it more because yeah,
yeah,
it's tricky.
yeah. It's a very nuanced conversation. I mean, I hammered in Harrisburg for 5 years, or well, yeah, and it was quite a challenge. Similar environment actually to what we're facing today. But we were able to break through with Republicans by changing the frame. We changed the name of the bill. We called it the
Interesting.
Family and Business Health Security Act, the Family and Business Health Security Act. It's a lot more friendly to the ears of more conservatives, and it actually opened the door for deeper conversations and that single payer hearing before a Republican chaired committee. The gatekeeper on healthcare in Harrisburg gave us a hearing. Nobody said, everybody said, ain't gonna happen, Chuck. No way, no how. So anyway, we'll talk about this more down the line. Catherine, your hand is up. Catherine Lewandowski is our treasurer.
Yeah, I
Catherine?
just wanted to share, some people have asked about the Florida county level plan. And we actually had a gentleman come, David Chase. I don't know, you probably can't see this. He wrote a book called Relocalizing Health during the COVID pandemic. I think he wrote it. It actually is pretty good. I personally, it's not that I'm against it. I mean, it is kind of, in my opinion, a baby step, but at this point, it's just like, I do feel like we really have to start saving as many people as possible at whatever level. But it actually, I've looked at it a little bit and it's doable for a local. The difference being with what I think Florida did is they purchased for-profit healthcare. This is a county just taking, or any community of any size, just creating their own healthcare system of providers and such, and using them, and I know that he's kind of talking with Seattle about
Great.
doing something similar to that. So,
Mhm.
Thanks,
And on
Catherine.
that point as well, it's definitely a baby step, but also, you know, local elected officials typically later become state elected officials and federal elected officials. And so you're kind of building those relationships, but also the know-how of how to create a healthcare program like this and the support. Because once you have that in a county, even if it's a red area, again, it opens the door to talk about shouldn't healthcare be this easy for everyone to afford kind of thing. So yeah, thanks for sharing that, Catherine.
mhm.
Okay. So we're turning to a New Yorker here, Barbara Harrison, who's from what town are you in again, Barbara?
I live in Ithaca.
Ithaca. Okay.
It's
If Dick Godfrey's still with us, I'd actually like him to come up and just comment on what I'm learning about New York is you may know this, Rachel, is that Lieutenant Governor is challenging the governor who put him there, right, in the next race, and he's running on single payer. He's running on the New York Health
yes.
Act. This is Antonio Delgado. So
It-
I'd like to see what your thoughts are on that. But Barbara, why don't you bring your question forward?
I
Maybe.
also was going to add, I saw Delgado speak a few weeks ago, maybe it's longer, in Ithaca. And if they would pay me to come and work on their campaign, I would be there in a heartbeat. He has not only is his single payer healthcare policy so positive for New York State and a good example, but he has other policies as well. And he's a wonderful listener and he cares about the people in this state. Anyway, my question
Yeah.
for you, Rachel, was wiser.
Mhm.
That that new, in Yiddish we say mishigas craziness that they are now putting forth with 6 states, and they use Medicare Advantage to want to try it out on Medicare. I'll let you put in your 10 cents since it's inflation.
Thank you for the question, Barbara. Um, and I've written a few pieces on this too on Healthcare Uncovered, broken down the model for folks who are not aware, but it's a pilot program within traditional Medicare, as Barbara mentioned, to bring in organizations who are doing prior authorization using artificial intelligence into traditional Medicare. So it's adding about 17 procedures that you're going to need prior authorization for in traditional Medicare, and it's going to be processed through those private companies. The first thing that I will say about the model is it kind of has it backwards because Medicare Advantage, as we know, does prior authorization incredibly inefficiently, but also inaccurately. So if you look at the numbers, a very small number of prior authorization denials are actually appealed, but 80% of decisions are overturned on appeal. So 80% of the time, these insurance companies are denying care wrongly. And if you look at the traditional Medicare program, again, those Medicare administrative contractors, they do prior authorization on a very small set of services. It's only about 50 within the traditional Medicare program. Things that are not going to impact people's care, and not going to delay it, but things that, there has been a little bit, some fraud or something like that in the past. So 50 services, if you look, they have a 97% accuracy rate within the Medicare administrative contractors on prior authorization. So if you asked me, I actually think the max should be teaching the Medicare Advantage plans how to do prior authorization. Unfortunately, that's not what we have right now. We at the Center for Health and Democracy have been pushing against implementation of the WISER model. There's also been bills introduced by Representative Pocan as well as Representative Del Bene from Washington, and Pocan is from Wisconsin, trying to stop it. We also recently looked at the participants that were chosen for this model, and unfortunately, but unsurprisingly, many of them are funded by private health insurance companies. So you have Optum Ventures, which is the venture capital firm for United Health Group. You have one company that is essentially Humana, but they kind of renamed themselves and set up a company over there. One company appears dormant since 2024, which was a little bit strange to us. A lot of companies have ex-executives from private health insurance companies, so very, very concerning all around. We're pushing against it. And also, at the same time, I do want to let people know that if you are in traditional Medicare or if you are choosing between traditional Medicare and Medicare Advantage, traditional Medicare is still going to be a better place in terms of prior authorization. It's only 17 services, it's only in 6 model states, and we are fighting against it. So if you're on traditional Medicare, I don't want this to worry you or to freak you out. The things to do right now are to push against it at an advocacy and policy level, and your care will hopefully not change. And if it does change, a lot of organizations who are working on this issue, like myself and other orgs, will be there to help you navigate it. So don't let this turn you away from traditional Medicare, but it's something that we need to push against. So great question.
Thank you, Rachel. And some people have had to fight so hard against Medicare Advantage till, I mean, you could die before you get the decision that's rightfully yours.
Mm-hmm.
Yeah.
Thank
Exactly.
you so much.
Thank you. Thanks, Barbara. So I did a name check with Dick Gottfried. I'm not putting you on the spot, Dick, if you want to come up and just comment briefly, because New York could be the breakthrough state. I mean, the stars might be aligning this way after next year's election. Do you want to add anything to the discussion, or just keep your tongue?
Well, it's it's certainly encouraging that Delgado strongly supports the New York Health Act. I mean, he's a very uh, captivating and outstanding public official. And he started out about a year ago talking about public option, and I sent him a memo about all the reasons why public option is not a good idea. And he read it, and the next time I saw him speaking, he was essentially quoting it. Um,
Awesome. That's amazing.
without attribution, but that's fine. I'm in a, I was lucky to be in a profession in which plagiarism was not illegal. But
Encouraged.
in addition to Delgado, the new mayor as of New Year's Day of New York City, Mamdani, in the 3 or so years that he's been in the New York State Assembly, was a co-sponsor of the New York Health Act. And so, we now have not only a significant candidate for governor, but the mayor of New York City being outspoken supporters of the bill. And the bill is actually co-sponsored by a majority of members of the legislature. The problem is that just about all of our public employee unions, state and local, woke up one morning in 2018 and realized that we now had a Democratic majority in the Senate as well as the Assembly, and therefore the bill might actually pass both houses. And so they, including a couple that had endorsed the bill, came out against it. And, in a state with Democratic majorities in both houses of the legislature and a Democratic governor, getting something done that's opposed by this wall of the state and local public employee unions is pretty tough.
Yeah. Yeah.
So our main need in New York, apart from, well, I'd say we need two things. One is a lot of organizations that endorse the bill for years have not really lifted a finger or raised their voice in support of the bill. More of them are starting to speak up, and that's going to be very helpful. And there's a lot more effort going on now to try to both negotiate with leaders of the public employee unions and to organize more of the rank and file to be pushing from the rank and file level to get their leaders to support the bill.
Yeah. Well, thank you for your insights there. Very, very helpful, Dick. We're going to keep a close eye and certainly stay active. And also just to say, and Rachel, you might know, we have a national state level legislator who is really gunning at this point, Carrie Reingans of Michigan. And she is organizing state legislative single payer leaders across the country. And she's creating really the fabric of an ALEC network, right? American Legislative Exchange Council that the right wing has used.
Mhm.
And she's a really, really terrific person. If you haven't connected, I certainly would want to do so at some point. Spoke with her just this morning. She's part of a strategy group that we're working on. Dick, thank you for your comments. Rachel, we're just about at the 75-minute mark. I don't want to weigh in on, I know you've got two little ones probably that you need to get to. I want to be respectful of your time and express gratitude. Do you have more time to take questions?
I have about 5 more minutes if
Okay,
there are any
okay.
other questions.
Yeah, and
Chuck,
we'd love for you to.
I
Oh,
just want to say it was always a pleasure to work with Dick Gottfried. He is a wonderful listener. And if like he said, he changed things in the bill if he felt that would be more inclusive and cover more people. But
yeah.
I have to say, I missed him. Misha Sogut was also his chief of staff, but
Yeah.
missing
Thank,
Dick, missing
thank,
him.
thanks so
Can't
much,
help
Thank
it.
you.
Barbara. Yeah.
Can't
It's that
help it.
nimbleness that we need in all quarters, right? So,
Yeah, wonderful person.
Yeah, we're going to go to Tom Sensick, who's our dear friend in Oregon. Tom, quick
Okay,
question.
thank you. I'm going back to the original thing. I put it in the chat early on, but Chuck picked the second question instead of the first one, which is you brought up the issue of focus on the insurance companies, not the hospitals. And can you talk about when we get that conversation, that back and forth blame, right?
Mhm.
How do you have any idea for strategies? And we're doing communications here to say we love our hospitals. They
Yeah.
are our delivery service. How
Mhm.
do we get people to get over that for at least for now and say, let's gang up on the insurance companies?
So you mean how do you get the hospitals to join with us, or how do you get people to stop
If you
attacking the
focus, if you
hospitals?
focus on the issue is that the insurance companies, not the hospitals, so we can get the hospitals to join us
Okay. Yes.
easier.
Yeah, that's a great question. So I think in terms of getting the hospitals to kind of join us, it's finding, and this sounds very simple, like it's going to sound kind of simplistic when I say it, but finding areas of common ground. So a lot of hospitals are fed up with private insurance companies. You're seeing that in their contract disputes, whether it's over Medicare Advantage or commercial plans. Becker's Hospital Review has a list that they keep updating of hospitals that are, going out of network with large insurance carriers, whether it be United or Aetna or things like that. Um, and the reasons that they cite are excessive prior authorization, excessive claims denials, and delayed payments. So private insurers are not only gaming patients, they're also gaming the hospitals. They do a lot of things where they approve a prior authorization, the patient gets the procedure, and then the insurance company retroactively denies it. So the patient has a large hospital bill that usually is not able to be paid. The hospital already provided that care. Even if it was an inflated price, they are not receiving any compensation for that. So that is an area that they are very, very frustrated about. And also, it's hurting their operating mechanics. Another issue that has recently gotten bipartisan support is many Medicare Advantage plans actually pay hospitals and providers lower than the traditional Medicare rate. And that is something that is also really, really frustrating to hospitals. It's hurting their ability to operate and provide services for patients. There's a bill that was introduced by Representatives Doggett, who is a Democrat, and Representative Murphy, who is a Republican, to require that Medicare Advantage plans pay at least the traditional Medicare rate to hospitals and providers. And also that they pay on time because private insurance companies also delay payments by months and months and months and months. Again, hurting a hospital's ability to operate and also making it harder for them to do their jobs. And so I think those areas of common ground are a way to kind of get hospitals to be, if not in coalition, because that might be too strong a word, in coalescence, kind of on the same side, pushing toward the same thing at this point. Again, none of this is to say that hospitals are innocent in all of this and that, nonprofit hospitals especially do not need reform, but there are areas that we can identify and talk about the benefits of single payer to hospitals would be not having to deal with that prior authorization anymore. Stable payments, not having to renegotiate contracts with multiple carriers every single year, not knowing if you're going to be in network with a carrier, things like that.
Terrific. Thank you so much for that. Rose Roach had her hand up earlier. I want to make sure that I didn't miss you, Rose. Did you have a question or comment?
No, I put it in the chat. It's just we have county-based purchasing entities here in Minnesota, and they are in very red areas of the state. And they literally, it's funny, Rachel, they call themselves managed care organizations, so they still qualify for like 340B and all of that, but they actually don't use private insurers as managed care organizations. So they're basically doing direct contracting, right?
Yeah.
Which is what we want to do with the whole state program. And of course, the Republicans in those areas absolutely love them, and they constantly brag about how well they're working. So we're like, so what the hell's the problem? Then why can't we just do it with the whole state, right? So expanding those and using those already existing infrastructures might be one way for us to think about moving towards that deprivatization if we're not able to just, pull the pin on the contracts overall for the entire state. So just wanted to mention that as people were talking about county-based, entities doing this work.
That's such a great point. And I also think from a communications perspective, using that experience, like you're saying, as a way to talk to people about what it could look across the entire, across the entire state. I brought up Libby, Montana earlier. They essentially have, single payer just for that area. Very red area. Everyone who is interviewed about it loves, loves, loves their Medicare coverage. And so that is, it's sometimes hard to understand why someone would be very opposed to Medicare for all, but like a program like that. But I really encourage us to use that as an inroad, right? Like, because we do need to have a massive movement to get this to happen. And so, maybe we use that to talk to people about what they like so much about their Medicare or their county purchasing organization, why they think it's so much better than a private insurance plan or something that they had before. So use it as an inroad to try and build support because we don't have to agree on everything, but I think most people agree that healthcare is way, way too expensive, way, way too complex, and also shouldn't be withheld from anybody because of cost.
Okay. Terrific. And there's Dennis Miller was asking about workers' comp and what becomes of workers' comp under the Medicare for All bill.
That is a great question and one I have not thought about in a long time.
How about since we want to let you get to your family, how about do you want to drop your contact information and email so that folks can
Definitely.
follow up and you can contemplate that question and I'm assuming this is the Dennis Miller who's not the right-wing comedian, right? That's somebody else. Yeah.
Chuck, can I just from a labor perspective, Rachel, think about it this way. I mean, the medical portion of workers' comp should just go away in a sense because now it doesn't matter where you're injured, right? It is about you're going to get the care you need. That's the one perspective. But the other perspective that labor worries about in taking it entirely away is that employers will stop being safe, right? Because they will think, oh, I mean, how will it affect the OSHA piece of this and employers feeling responsible to provide a safe working environment, right, for their workers. So it is a bit of a conundrum. I mean, my head immediately went to why would we need medical care under a comp system, and which is the biggest portion of the cost of comp, right, for an employer, because I've been on the employer side as well, right? If we could remove that, oh my gosh, that could get employers on board really fast. But then it's like, let's just make sure if we do that, we still keep all the safeguards in place that are going to ensure that workers have safe working environments. So just something for the center to maybe think about as we get deeper and deeper into, possible policy with Medicare for all.
Thank you so much, Rose. And I think, your perspective is always so, so helpful, especially as we talk about getting labor on board with this, because it's not just getting them on board, it's also making sure that the policy is going to work for them, right? Because we could have the best policy on paper, but if we don't understand how it's going to affect workers who are in a union, even if they're not unionized, things like that. It doesn't matter if the policy looks great on paper. So I really appreciate that. And that did remind me of something. Something that's not talked about a lot is that malpractice insurance for physicians would also likely greatly decrease because a lot of malpractice suits include future medical costs. And so if there's no or very limited future medical costs, there's a lot less costs for malpractice insurance in other countries. The costs are much lower. And so another thing that doesn't relate to labor, but relates to physicians and hospitals.
Yeah, terrific. Catherine, your hand is up. I know we're trying to get to wind this down. Is it okay if we just keep going? All right. Catherine, did you have a really quick one?
I just wanted to respond to Rose's comments
Be very
about
quick. Yeah.
L&I because we've had those concerns too, although we feel it's covered that because the medical aspects would go away, but there is still a need for L&I for safety and for rehabilitation, maybe retraining to a different job if they are injured and can't do their same job. But somebody mentioned something just today at our stakeholders, I think it was today at our stakeholders meeting, that the infrastructure that we currently have in the state for paying our L&I claims could be part of the infrastructure to pay our universal health care plan benefit.
All right.
So
Interesting.
Thank you, Catherine. Rachel, just final comment, and let's keep this going. I really am grateful for your time and thoughtful exploration of questions and different pathways. Yeah, this is what we have to be doing. We have to be really creative. Thank you so much.
Of course, and thank you so much for having me and for all of the questions in the discussion. I truly love talking about all of this and with all of you. So really appreciate the invitation.
All right. Well, happy
Bye.
holidays, everyone.
Rachel, you must have a great partner.
I
You have a
do.
wonderful partner.
Yes, I
Yeah,
do.
yeah. Have a great holiday.
Thank you. Happy holidays.
Okay. Love to everyone. Thank you so much.